Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in another demonstration video of our soon to be launched WAXscope. In this particular case, I have a patient who attended with bilateral fully occluding dead skin filled with keratin. So the outermost layer of skin, the epidermis, as that skin dies, it fills itself with keratin, which is a protein that's also found in our hair strands and fingernails, and keratin is hydrophobic, so it helps to repel unwanted water in the ear. In addition, keratin has a protective property in such that it reflects harmful UV rays from the sun, so it helps protect the underlying skin. But in this patient, this keratin has just built up. They are a hearing aid wearer, and they have to attend biannually. And I suspect the occlusion is due to two reasons. The skin is very, very dry indeed, and there's a lot of adherence to the canal wall, preventing it from migrating out of the ear sideways, which it should be doing. But also, the patient's hearing aid itself is not helping because it's preventing this dead skin from migrating. In fact, it's pushing it further in, one could argue. So I'm just using the new right correct there, and I'm just trying to separate it all the way around the edge of the ear canals. So this is the back part of the ear canal. I'm just lifting that away. You can just see how strongly adhered that is. With keratin, you quite often, because it has got this reflective property, you can see it's reflecting a lot of the light source that we're using to illuminate the inside of the ear. Earwax is a bit more softer, less reflective, so it absorbs a bit more of the light, whereas the keratin reflects. You can tell by the glossiness of dead skin, it is a lot more reflective and shiny in comparison to earwax. The specular size we're using here is a 5mm specular. It's a large size. We've got an extra large, 5.75, and then we've got the standard size, which is 4.25. And then we've got a 3.5mm. Now, the 3.5mm internal diameter speculi, I initially expect to just be using for pediatrics or children, but I'm using it more and more, and that's because a lot of patients who do have earwax impaction, a lot of adults have got narrower ears. So it makes sense for me to then also be using the smaller specular in this patient group. So, but you've got a 4 to select from. Slowly bring this forwards, and the distance some of this keratin is adhered to the eardrum. Just change the focus there so we can view that. So with this patient's keratin, the surface keratin of this plug is quite dry and crusted, but in the core it's a bit more soft and mushy. So you can see with the correct, as I'm bringing it forwards, it's almost spreading the core of this keratin plug against the canal wall as opposed to bringing it sideways. So I've just gone back in the correct. I'm going to lift it up. I think in a moment I am going to be reverting to, or a bit later on, some forceps. At the moment, there's nothing substantial for me to grab onto. If I was to use forceps at the moment, then it was just going to, you can see it's quite crumbly, this more lateral aspect, and it will just tear away these crumbly bits, which is not the idea behind the forceps. Forceps, we want to grab onto something substantial and then bring this keratin plug out in a larger piece. So I'm just readjusting the focus. I'm just going a lot deeper now with the correct. You can see that the tail end of that skin is coming down off the eardrum. So I've got to be careful with the correct. What I have found with the WAXscope is that because of the angulation, because the specular is straight in the ear, as opposed to the endoscope, that I am able to use insert instruments a lot deeper in the ear than I previously was able to. Got a nice piece out there, just rolling it out the ear. Just stretching the ear once more. So we've probably got 2/3 out. Just getting it in focus. You can see all the keratin there, you can see all the texture of it, the structure of it, the helical structure. You can see the ribbons that are quite normally associated with dead skin. You get this ribbon effect, and you can see the ripples on there of the individual skin cells that they have a lamellar structure. So these skin cells They are flat shaped, so they call that squamous, and they're interlocked in a lamellar structure. Think about fish scales, how they interweave and overlap, or even tiles on a roof. So, or body armor, historic body armor, not the modern day body armor. These plates of armor, they're interlocked. Fish scales are interlocked. Tiles on the roof are interlocked, and similarly, our skin is also, individual skin cells are interlocked. But as they die, they begin to disconnect from one another, and they flake off into their individual skin cells, or they should do. And slowly but surely, these little individual skin cells, they fall out the ear, and quite often you may be able to feel that sensation. You may get a bit of an itch, and then you can feel something dropping out your ear, and that's your wax and your dead skin. So again, I'm just pushing this off the posterior canal wall. I'm just trying to go over it now and bring it forwards. But I think now I've got something more substantial to grip onto using the forceps, so we shall see if I use them. Maybe not quite yet, but we shall see. You can just see how compressed this keratin plug was on the back part of the ear canals. When we moved it forwards, there's a bit of inflammation there, a bit of almost like a bruising. And that's just caused by the pressure of this keratin plug up against the canal wall. Of course, when the patient then wears the hearing aid, it's going to cause further compression. And we just roll that out the entrance. And there's a fair amount of skin here. So I'm just having a good nosy around, getting my bearings. So again, I'm going superiorly, getting in and behind this and slowly bringing it forwards. So the corrector worked really well so far. I think I'm going to readjust the focus. I am, just so we can see the anterior part of the ear. There's a bit of keratin here that I'm going to elevate off. You can see the underneath layer of skin, that whiter layer, that's more recently dyed and shedded skin. And as that skin matures and oxidizes in the ear, it darkens. The darker pieces of keratin is the older pieces, whereas the more lighter shade is the more recent dead pieces of skin. So we got another piece of dead skin out here. So we've already got a quarter left. You can just see the curvature there with the keratin. It's a lot more visible with the right keratin in comparison to when we're using the endoscope, the eye clear scope division, when we're using the keratin in conjunction with the eye clear scope, should I say. Well, you can still see it, but with the WAXscope, it's a lot more evident, the curvature. So now it's a good time to use the forceps. Again, I'm just trying to, the little gap here, just sort of lift it up. There we are. I can get the bottom jaw underneath. I'm going to grip. I'm going to separate it. Got a nice piece out there, but as I predicted with this consistency, because it's quite dry and crumbly, the peripheral anyway, it's just almost dissected it into two pieces, but I'm going to go back in. And we've just got another piece that's got an additional piece hanging off it. So the occlusion is now removed. You can see as we remove some of the skin, there's a bit of blistering at the base. The eardrum is visible, there's some keratin on there. So I'm going to revert to the fine end suction probe now, and I'm just going to peel away some of this dead skin. So it's quite deep. It is about 0.5 centimetre away from the eardrum, so we're on the bony, sensitive part of the ear, so we do have to be cautious. You can see some individual hair strands that's sitting on the surface of the skin that I'm going to peel away. And slowly but surely, I'm just lifting this up. I'm just going to reduce the brightness so it's slightly, because it is quite reflective. There we are. And all these adjustments in terms of the brightness and focus, they're all done quite easily on the app. I had a colleague visited me today just to take a look at the WAXscope. They are using the endoscope already, but admittedly they said they can struggle at times to use it. Using an endoscope is a really skillful art to master. And they're really interested in the WAXscope. They are using these head-worn loops in the meantime, and they were taken away by the view, the magnification, the clarity that the WAXscope is able to offer. It's far superior to what they're using with the loops. So it's just some skin at the roof of the ear canal. Let's see if we can peel that away. Slowly peeling it downwards. And there's just a bit of crusted skin centrally. So if it comes away easily, brilliant. If not, we're not too concerned. But I'm just hovering over this and it just came away. You can see a few flakes of dead skin that we peeled off. We're going to leave that. You've got to know when to stop. It's probably one of the hardest things as a clinical ear care specialist. Sometimes less is more. Even pieces like this, if it didn't come away easily, we just left it. But thankfully, it came away without too much trouble. And again, there's a few flakes at the base of the ear canal, so we're just going to hover over. If they come away, brilliant. But we're not going to force it or chase it. So it's going to adjust the focus. So just got the tail end of that. We're going to leave the rest. And I'm just going to mop up these little fragments of skin. So these are quite crusted now. And I'm just going to visualize the patient's eardrum. I'm going to get it in focus. I'm going to adjust the brightness there and then the focus. Just going to stretch, dilate the ear so we can see the anterior part. So you can see how we're manipulating the speculum so we can get the full view, even the front section of the eardrum, which we previously wasn't really focusing on. And we're going to move on to their left ear now. Sorry, their right ear. That was their left ear that we just treated. So once more, it's really reflective. Just going to turn down the brightness. So this plug of keratin, it's fully occluding the patient's ear canal. So it's all the way around the edge. There's very little openings or gaps for sound to travel through. Once more, I'm just commencing with the right keratin, and I'm just elevating it downwards just to peel it off the roof of the ear canal. And as I am, I'm bringing the keratin forwards out of the ears, so laterally, to try and extract this. You can see the WAXscope offers a lot more magnification than the endoscope, but it doesn't offer the same field of view, and that's the beauty of an endoscope. With an endoscope, the lens of the endoscope is inside the ear, hence the name endoscope, which then provides you with an unparalleled field of view. With all of the visualization techniques, the lens is actually external, so it's out of the ear. So, like an ENT microscope, head-worn microscope, loops, operating otoscopes, the WAXscope, for example. And that can make it more tricky to visualize the full eardrum. Because the ear canal's not straight. If it were straight, then it wouldn't be a problem, but the bends and twists and curves in the ear, meaning that if the lens is outside of the ear, you can stretch the outer third of the ear canal quite a bit to try and straighten it and align it with the inner 2/3. So the curvature typically occurs on the outer third of the ear canal from the first and second bend. So and that's cartelineous, so if you can stretch that and straighten it in line with the bony part. Now the bony part itself can also be curved and bent, but it's less so than the outer third. So once you straighten the outer third, then you've almost got a straight line towards the eardrum. As such, not always, but as I said, it does help. But sometimes it's not possible to fully stretch and dilate the ear canal because it can be uncomfortable for the patient. So here I'm pushing the speculum to the left and then rotating it back to the right to get a straight line. You can see the eardrum in the distance, it is more central. On the right, you can see that flesh there, that's the bottom of the second bend of the ear canal. Everything beyond that is the bony part, and you can actually see the border. So the cartilage portions appears more fleshy, it's more matte in appearance, more dense, paler in colour, whereas the bony part, it's shinier, it's more red, it's glossier. So we just use a combination of the forceps and now fine end suction probe. I'm just lifting this up. I'm going to adjust the brightness, I think. There we are. So the ear canal is now unblocked. I'm just going to visualize the patient's eardrum. There is some keratin around the edge, so let's increase the brightness again. There's some keratin there. We're going to see if that peels away. And slowly, you're just going to peel it downwards. Again, it's quite adherent to the roof of the ear canal. It is like sticky sellotape. So we've got to be careful there because we are on the patient's eardrum here, so it can be nice and gentle as we peel it downwards. I think it will just tear away in a moment. We're going to peel it inwards now because we're working on the back part of the ear canal. So we are going to get these little flakes. It's not significant. It's fine. Even that skin that we just peeled there. For anyone new to removing earwax, I'd recommend probably just leave that. It's just when you're more experienced. And if it's not causing the patient any discomfort, you wouldn't. If this was causing the patient discomfort, then we would stop straight. Or if it was clarinetting, so making a loud high frequency squeal, which it wasn't, fortunately, you would just stop the procedure because you don't want to add any additional risks. These patients are regular, they're very cooperative, very still, and there's no clarinetting, no discomfort. I felt comfortable just trying to peel away as much of this dead keratin as I possibly could. On the centre part of the ear, I'm going to peel this down directly off the hammer bone. It's also known as the malleus. Just increasing the brightness ever so slightly. So if you are interested in the WAXscope, please feel free to email info@clearwax.co.uk. I have done one or two smaller training courses just trying to refine the whole process before we do the big launch, and all the speculi and all the instruments that I'm manufacturing are in mass production as we speak. Everything's registered with the relevant regulatory medical boards, both in the UK and in Europe, so it's CE marked. Just got a couple of other additional things to sort out, but we are there, which is great. We're getting some really good feedback as well. So I recently trained two good friends. One's an ENT consultant surgeon, one's an audiologist. I was a bit worried about the audiologists because they are very proficient with the endoscope. And as I've explained before, this is not a substitute for the endoscope. The endoscope, as far as I'm concerned, it's in a league of its own when it comes to visualising and removing earwax from the ear canal. So I was worried that when my colleague reverted to the WAXscope, it would be a bit of a coming down, if anything. But they were really impressed. And yeah, there are obvious differences. But in certain cases that my colleague isn't able to do with the endoscope, they are using the WAXscope. And in fact, they're gaining a preference for the WAXscope now. My colleagues an ENT surgeon, they quite regularly use an operating ENT microscope to obviously perform surgery, but also to visualise the ear in outpatients clinic. And they were really impressed because the view is more akin to a microscope. It's something that they are more familiar with. My colleague wasn't familiar, or my other audiology colleague wasn't familiar with the microscopic view, but the ENT surgeon was, and really impressed. In fact, they said it was better in terms of view for removing earwax than an ENT microscope. The only major difference is with the microscope, ENT microscope, you gain depth perception using binocular vision. So both eyes are artificially converged to be able to view deep wax, or try and view deep wax with each individual eye. When you're viewing an object with both individual eyes, your brain can use the information received from both eyes to provide depth perception. So if you cover one eye, shut one eye off, you lose that, you get monocular vision. But it's not to say you can't gain depth perception with monocular vision. And essentially what we're using here is monocular vision. But the depth perception here it's obtained by focus. With the iClearScope endoscope, similarly, that's 2D view, so it's monocular vision, but you gain depth perception with an endoscope. I would say more because of the wide field of view it provides, the shadows, the various landmarks, that enables you to obtain depth perception. But with the WAXscope, it's mainly to do with the focus, and when things are in focus, you can judge the depth. So in the eardrum, in the distance, we know that's far away because it's blurry. Whereas this piece of skin at the roof, we know we can ascertain the correct depth because it's in focus. And I'm just in focus to visualize the eardrum again. I'm just going to increase the brightness and adjust the focus. So I'm very pleased with that. Patient's hearing aid stopped whistling, as that was one of the complaints that they had. You can see this patient's got a really dry ear canal, superficial otitis externa, partly due to their age. As we get older, our skin is less able to maintain its internal moisture. There's less production of sebum and serum, which are these oily sweats and lipid oils secreted in the outer third of the ear canal. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.